How many of you have idea about ventilators? How many of you have ever used ventilator or operated ventilator?
Yes, ma'am.
You have,
Yes, ma'am.
Shashikala? Okay, then I have a good candidate to discuss with. So, let's talk about ventilators. What do you mean by ventilator, anyone?
It's a machine, ma'am. It's providing providing oxygen, or
Tell me one
it's
thing.
something setting.
Why do you need ventilator if you have oxygen? You can also provide the same oxygen with your mask, venturi mask. Then why do your patients be on ventilator? What is the purpose of ventilator?
It is non-invasive procedure, ma'am. And in ventilator, people who cannot take their own breathing, like there is no respiration rate.
They cannot
Take
They
inspiration, expression.
Sorry, I didn't get.
they under unconsciousness. They under sedative. So that time they will not respiratory muscles also sedative. So that time we can use the ventilator. Um,
No, ma'am,
and
there is
also,
no proper gas exchange, ma'am, in the lungs.
Therefore, gas exchange. Anyone else who want to put their views?
There is no inspiration, expiration pressure.
Anything else? What is AMBU?
go back.
What is this?
Artificial
Arms.
Artificial manual breathing unit. It is a breathing unit. This will help you to breathe. Okay. Ventilation means.
No, ma'am. Can you say it again, ma'am? Artificial?
Artificial manual breathing unit. Okay. Tell me one thing. Are you all aware with physiology of breathing?
Yes.
Okay.
Yes, ma'am.
Tell me what is the physiology of breathing then?
Good evening, ma'am.
Good evening, Uzma. I was waiting for you. Yeah.
Hi, ma'am.
Hello. Okay. How are you?
Hello.
Hello, yeah.
Hello,
How are
ma'am.
you?
Hello.
Yes. Hello, is audible to you?
Hello.
Hi, good evening, ma'am.
Good evening.
Hello, ma'am.
Hello. Is audible, Uzma, to you?
Yes, ma'am. Oh,
Okay.
Usman, sorry.
No, I'm also waiting for you.
Hello, ma'am. Hello, ma'am.
Hello,
Good
Uzma.
evening. How are you,
Good evening.
madam? Are you hear me?
I'm good. How are you?
Fine. Madam, are you hear me?
Yes, I do. You need to choose just a bit. Okay, Kawaljit Kaur, you're late in class.
Hello, ma'am. Are you hear me?
Yes, I can hear you, Uzma. I can hear you.
Okay, okay, ma'am. आवाज आ रही थी.
It's okay. Just change your setting or just change your location for some time. Then it's going to work fine. Okay.
Okay, ma'am. Thank you.
Okay. Kawaljeet, Priya.
Hello,
Yes.
good evening, ma'am.
Good evening, Priya. Good evening, Kawaljeet. You look pretty. You don't have to hide your face behind your hands. I'm just okay. So let's start. Now it's fun to stay relaxed. And Suben, I also appreciate your presence. It makes me feel good. Yes, Farhad, you also. So I got students with me now. It's cool now. Let's talk about ventilator. And ventilator is very, very important topic. Everyone, be active, be attentive. Okay. Let's start about ventilator. Now, I will speak. Then you will all reciprocate. Okay. So you all are very, very, very good aware of this physiology of breathing. That how do we breathe? We breathe when we breathe in, when the air will pull into your airway, when there's a
Oxygen.
And when there is an increased pressure.
increased pressure, when they decrease, when we increase volume, the pressure will decrease.
Pressure will decrease.
Then the air from outside, from higher pressure to lower pressure, and the air will move inward. This is the basic physiology of breathing. And when we decrease volume by relaxing this diaphragm, the volume will get decreased, hence pressure will increase. So the carbon dioxide will escape out.
Exhale.
This is all we have studied till now, right? A
Yes, ma'am.
basic physiology of breathing. Now comes a part when you're somewhere, somehow, your diaphragm is not working properly. Either you get sedative, either you receive muscle relaxant during surgery, or you are under anesthesia, or you got injury, or there is so much of compression into your airway that this mechanism is not working, and this mechanism is not enough to provide you enough blood oxygen to your blood. Then we will use a machine which is called a ventilator. Listen one thing. Ventilator is one of the most easiest thing to study. What is ventilator? Ventilator is a person. Just understand how ventilator works. Okay. Just imagine ventilator is a person whom you have given some instruction. Okay. And this person, this ventilator, follow all your instructions that you have provided to the patient. For example, you ask patient to give
Respiration.
respiratory rate, volume, pressure, okay, and what is the fraction of oxygen that you want to give. So what basically ventilator is, ventilator helps you to inhale and exhale your oxygen. It is a ventilator. It helps you to ventilate air, to put air outside to inside your lungs, and to remove carbon dioxide from your lungs to the body. This is just a simple machine from where you will put an ET tube, endotracheal tube, and this will just give oxygen it will force force air into your lungs and remove carbon dioxide with different setting of pressure. This is what ventilator do. Understood?
Yes,
Clearly?
ma'am.
Okay.
Yes,
Now
ma'am.
understand one thing that state that, okay. So just imagine ventilator is a boy, okay, and you have what just imagine I'm a ventilator, okay, and here's the patient, and my role is this. I have given some I have connected one oxygen tube to the patient and second to the air or oxygen tube, and this is the machine, like this is the me, okay. So this is the ventilator. So what is this ventilator? So I want to give oxygen. I want to manage the patient. I want to manage the respiratory function of a patient. How will I manage the respiratory rate of function? How can I? What is the basic function of your lungs? What is the basic function of your lungs?
Inhale and exhale.
Inhale, exhale.
This is the
O2.
function of your nose.
Inhale the carbon O2 and exhale the CO2.
This is the function of your nose, not your lungs.
Okay.
Oxygen to
Purify.
the body, or you can say blood.
And carbon dioxide.
Yes, this is the basic function of your lungs. Okay, this is what you want ventilator to do it for you. Yes, this is what you want ventilator to do it for you. So if you want to make this thing, first of all, you will ask about breath. Yes, breath. Breath is, what is breath? What is respiration rate?
18 to 20.
No, this is the normal respiration rate, yes, but I'm asking what is the breath? Taking in it and exhaling it out. Yes. So, first of all, if you want to ventilate a person, there has to be a rate, like in 1 minute, how many breath I am giving to a patient. This is, I should know. This is what you need to tell the ventilator. Okay, listen, ventilator, I want to ventilate my patient at a rate of 15 breath per minute. What do you mean by this thing? Mean that, okay, this is the ventilator. And first thing ventilator will ask you, ki, what is the rate? At what rate do I need to give oxygen to the patient, or do I need to give air to the patient? So you will tell a rate to a patient. Yes, a respiratory rate. So, or you can just call it as breath. Okay, breath. So there are two types of breath. One breath is your mandatory breath, and second is type of breath which is known as spontaneous breath. Mandatory breath and spontaneous breath. What do you mean by mandatory breath? Okay, listen, Shashikala, I'm giving an instruction to you. It is a mandatory work for you to ring a bell 20 times in a minute. Understood? This I'm
Yes, ma'am.
I'm telling you, listen, Shashikala, this is a bell. So you will press bell 20 times in 1 minute. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So in 1 minute, you need to press this bell. So this is called mandatory, something that I have mandatory. This is mandatory. You have to do mandatory. You need to study for Nclex. This is mandatory. So this is mandatory breath means what we have given, instructed to a patient, instructed to a ventilator to give a mandatory breath, like this much of breath should be given at 1 minute. Understood? Mandatory breath.
Yes, ma'am. Yes,
Everyone.
ma'am.
And there's some kind of breath which is called spontaneous, that patient itself take breath. Like spontaneous, the patient, like, okay, some muscle movement happened, some trigger in your brainstem, pons, especially your pons, and they trigger and spontaneous, patient is taking the breath. Okay, this is the spontaneous breath by the patient. Mandatory breath given by the ventilator. Understood till now? So there's one
Yes,
setting that
ma'am.
you will do to a patient, that you will ask patient, no, not the first setting is your rate. So you're going to fix the rate. Thank you. Fix the rate. Two type breath, mandatory breath and spontaneous breath. Okay, mandatory breath and spontaneous breath. So mandatory breath, for example, I said that, okay, ventilator, listen, there you need to give 15 breath in 1 minute. So this is the mandate. So I fix the mandatory breath, like 15 breath in 1 minute you are going to give to a patient. Then how many, one breath will take how many minutes? Can anyone calculate? 60 seconds is equal to 15 breath. 1 second it is equal to 4 breath. No. Just I'm so sorry. Okay. 1 breath is equal to 4 seconds. Can you just divide 60 by 15? 4 will come. 1 breath, you want to take 1 breath. So at every 4 seconds, for example, like 1, 2, 3, 4, breath. 1, 2, 3, 4, breath. So what ventilator is doing? So I'm taking, and this is my oxygen mask. So I'm like 1, 2, 3, 4, breath. 1, 2, 3, 4, breath. 1, 2, 3, 4, breath. So this is what your ventilator is doing. At every 4 seconds, it is giving 1 breath, because you have given, you have mandatory told the ventilator to give 15 breath per minute. Understood? This is
Yes,
the number one function of this breath. Okay. Now the ventilator will ask you, ki, Master Sahab or dear doctor, you have told me to give the breath. I'm giving the breath, but can you tell me at each breath what is the volume? Second question will come. Like, okay, for example, at every 4 seconds, I'm giving 1 breath. So my 1 breath will contain what, how many volume of air? So next, second question comes your volume and pressure. So second setting will come your volume and pressure. Now comes a good question. Ventilator will tell you, listen, Dr. G, you can do only 2 things. Either you can set the volume or you can set the pressure. So there's only either one of them. You can set the volume or you can set the pressure. Both of them you cannot set, because if you set the volume, the pressure will be generated by the ventilation, because volume and pressure depends upon the compliance of the lungs. For example, you want to give 500 ml at each breath, okay, but the lungs walls are very stiff, very stiff. If you give more, just imagine lungs wall, like it has become a patient is of ARDS or atelectasis. So if you want to give 500 volume, the machine will give 500 volume, but and just imagine you have set a pressure of 20 mmHg or 20 centimeter of water. Both are the measuring unit of your pressure. You should know this thing, okay? So if you set the volume as well as if you set the pressure, your ventilator will can't able to, because ventilator will assess the compliance of your heart, and according to that it can decide if you're giving the volume, the pressure will be decided by the lungs, and if you're setting the pressure, the volume will be depends upon the volume. If you set the volume, so the pressure will be decided by the ventilator. If you set the pressure, the volume will be decided by the ventilator. Understood? So either ventilator will second question ask you, you can decide volume or you can decide the pressure. It's up to you. Understood till now?
Yes, ma'am.
Everyone? Okay. Now,
Can you recap, ma'am? Just
yeah,
a glance.
So let me explain you in a very quickly what ventilator is. So just imagine this is a ventilator. One end is connected to the oxygen, and this is a machine, okay, and the other end is connected to the patient, okay. So ventilator is a middle person, okay. So ventilator is like a person who is giving oxygen to the patient, okay, and ventilator, you will give some instruction to the ventilation. So what are the instruction? The first instruction will be your breath. There are 2 type of breath. One is your mandatory and
And
second is your
spontaneous.
spontaneous. Mandatory means fixed, can't change. Mandatory means you want to give 15 breath per minute. So 1 breath will be every 4 seconds. So every like 1, 2, 3, 4, breath. Then again 1, 2, 3, 4, breath. So every 4 seconds, machine is giving breath to a patient. Next, second question comes, at each breath, how much volume of air will I give? So you can set the volume. So if you set the volume, the pressure will be, okay, so ventilator will, okay, I want to give 500 volume to this lung. So according to the compliance of my lungs, it will be 20 mm of 20 mmHg of pressure I'm going to insert. Okay. If you set the volume, the pressure will be decided by the ventilator. Okay. So because these two settings depends upon the compliance of your lungs. Okay. Understood? Just imagine there is a patient of atelectasis. Okay. The airway is completely collapsed. And you have set a volume of 500 and you set a pressure of 40 mmHg. So ventilator will do. Ventilator is your gin. Whatever you will ask ventilator to do, ventilator will do. But when you will set the both of the thing, the alveoli will rupture. The alveoli will rupture. Too much of pressure, alveoli will rupture. The patient will be go in arrest. Okay,
Respiratory
air will
arrest.
come. Yes, rupture of the airway immediately, and this is a medical emergency. Barotrauma will happen, and the patient no breath sound, airway rupture, medical emergency. Understood?
Yes, ma'am.
And there's a characteristic
Yes,
feature
ma'am.
associated with it. Even you're looking at the machine and you're like, okay, I'm giving 500 volume, and when I'm checking the ABG or I'm taking a SpO2, it is come out to be 16, oxygen is coming out to be 60. How can it possible? It means that the airway has been ruptured, the body is not getting oxygen, and this phenomena is called as paradoxical hypo. This is called as paradoxical. Anybody know this term?
No, ma'am.
Paradoxical hypoxia. In spite of giving oxygen, the patient is not getting the blood values are not the blood is not taking oxygen. Because alveoli is rupture. Who's going to exchange gas for you? Trachea? No. Trachea is very thick. No, it can't. Understood?
Yes,
Everyone.
ma'am.
Yes, ma'am.
Ventilators clear हो गया सबको. Very easy. Don't get worried about ventilators. Okay. Ventilator is just a simple machine. Something is written over there. Don't go for very, this is the basic of ventilator. So many settings, you know the basic, you can just learn it. Not mushkil. There will be some more settings. Simple machine. Okay. Now let's talk about modes. Okay. Let's talk about mode. And they listen one thing very, very clearly. There are so many modes of ventilator. When you work in hospital, you must have seen so many modes of ventilator. But what is important to
Yes.
Nclex? What at least should you know? What basics should you know? I'm going to teach you that. Okay. Don't come and say that, ma'am, you didn't teach that or something, because this is not important. Especially talking ventilator is not a part of your Nclex also. Because I wanted to make a very firm basis of you all. That's why I'm teaching you ventilator. So you know ventilator very, very well. And any question by chance comes to you, you can easily tackle them. Okay. The first mode is your CMV. Can anyone tell me the full form CMV mode?
Madam, control mandatory ventilation. Hello?
Yes, yes. Thank you so much, Uzma. I understood. Now you will tell me the answer, Uzma. You know the meaning of mandatory now, everyone?
Yes, ma'am.
Yes, ma'am.
You know what is control?
Yes, ma'am.
Yes, ma'am.
You know what ventilation means?
Yes,
Can you tell
ma'am.
me exactly
Yes,
what is
ma'am.
going to
Yes.
happen in this ventilator? You means doctor will set the mandatory breath. So you have just set a mandatory breath. Like for example, mandatory breath is 15 breath per minute. So whatever happen, Your machine is going to give mandatory ventilator. Anything happen, patient taking breath, patient not taking breath, doesn't mean to you. It will not affect you at all. It will not affect the ventilator at all. Ventilator will going to give you 15 breath per minute. It is going to give you 15 breath per minute. This is controlled mandatory ventilator. It does not recognize your breath, patient breath at all. You have fixed the tidal volume. At every breath, you're going to give the breath to the patient. Ventilator will going to give you. Pressure will be fixed by the ventilator itself. So there are only two. Listen, breathing is very easy. Inhaling some amount, exhaling some amount. Okay. So this is the thing that we should know. This is exactly what your machine is also doing. Machine is not doing anything extra. Nothing fancy. We had just add something. Nothing more than this. This is nothing more than these all three things that we should know. Next comes your ACMV. Okay. So how many of you lives with their parents? Okay, tell me how many of you are parent? A good question. Now it's a very okay, Kavaljeet saying. Kavaljeet Kaur. So what exactly happened when you try to feed your kid? Your child is hungry, so you will feed the food?
Yes, ma'am.
Yes. And even if your child is not hungry, still you want to feed the food?
Yes, sometimes.
This is exactly what ACMV mode is doing to your lungs. They will give you food, they will give you oxygen as you have set in the machine. And when the patient try to take more breath, what machine will do? They will help you with more volume. Are you getting my point? Just
Yes,
like you as a parent. So what is happening? So this example, okay, just I'm taking example of Kavaljeet. Okay, Kavaljeet might be having a doctor. Don't say that you have a son. You have a daughter or a son.
Son.
Okay, just kidding. So you have a son. So you have decided a meal for your son that at 10 a.m. you're going to feed the child. At 2 p.m. you're going to feed the child. At 6 p.m. you're going to feed that. So you have just fixed the time. Okay. So at this time I'm going to feed. At this time I'm going to feed. So this is the time. Just imagine your child comes to you at 1 p.m. and say, I'm hungry. Will you feed it or not? So
Yes,
you will
ma'am.
again
Yes.
feed it at this 1 p.m. and you will feed it at 2 p.m. because this is the time you had fixed. So here comes your ACMV. ACMV modes as control for assist, control, mandatory
Ventilation.
ventilation or breath. Yeah, ventilation. Assist, control, mandatory ventilation. So let me write it more very clearly so you all can understand. This is your assist, control, mandatory ventilation. Okay. So what is happening? There's one control mandatory ventilation. So there's one mandatory ventilation written. So this is your mandatory ventilation at 10 a.m., at 2 p.m. or 6 p.m. So the mandatory ventilation is 15 breath per minute. That come out to be 1 breath is equal to every 4 seconds. So one thing you have decided that every 4 seconds, 1, 2, 3, 4 breath. 1, 2, 3, 4 breath. So this is your mandatory ventilation. Everyone understood?
Yes,
Now
Yes,
comes
ma'am.
the one more point. What is this assist control? It means that just imagine at this time. So mute yourself. 1, 2, mute yourself. Who's this? When I say mute yourself, means everyone just mute yourself. Okay, listen to me very carefully. Assist control means, so just imagine patient is taking 1, 2, and patient want to take breath. So the patient is pulling its diaphragm downward, and ventilator will get a sense because there will be a negative dip in the in the graph. So there will be a negative dip in a graph. So the ventilator will get a knowledge that the patient want to take breath. So at that time, the ventilator will give a assist, means patient ventilator will give some volume of air. So the volume of air the patient is getting at third, and then fourth, then mandatory ventilation. So at a duration of 4 seconds, there is one mandatory ventilation and there is one the patient that is trying to take itself. Understood ACMV mode very, very clearly, very, very easy. So you're just filling air into the patient. Okay. This is a very good mode when we want patient to breathe itself. We're just helping the patient, but we are hyperoxygenating the patient. And when we hyperoxygenate the patient, your pH goes hyperoxygenated
Alkaline.
patient, alkalosis. Patient will go in respiratory alkalosis. Might be some extreme cases. Will hyperoxygenate the patient. And when there's too much of oxygen in the body, your CNS sleeps. You feel very drowsy. You know this thing? When there's too much of carbon dioxide, you feel very agitated. You know this fact?
Alter sensory. Yes, ma'am.
Yeah.
Irritated, alter sensory.
Yeah. Did you understood about ACMV mode? Everyone, very, very clearly, very, very easy. Okay.
Yes.
Next, let's talk about this one more ventilation, which is called PCV. What do you mean by PCV? P stand for Uzma?
Mature.
No. What is PC mode? PCV mode, PCMV mode, PCV mode, sorry. Pressure.
Pressure
Pressure control ventilation. Can you tell me what does it mean? In this setting,
only the pressure we
yes.
have to control.
Yes. So over here, you will only control the pressure. Okay. So you will control the pressure. You will control the pressure. So you will go and do the setting. Listen, breath. So you have to always control. Pressure also. Then you will, if you control the pressure, then volume will be decided by the
ventilation.
By the ventilator. So this mode is very good when the patient is having atelectasis, because you don't want to create barotrauma when there is so much of restrictive lung diseases, when the very stiff lungs walls are. Understood?
Yes,
Name
ma'am.
itself tells everything. If you know the basic, you know everything. Next, control SIMV mode. What do you mean by SIMV mode?
Ma'am, ये synchronize intermittent mandatory ventilation.
Synchronize
Nice.
intermediate
mandatory ventilation.
Very good. And now let me clarify one thing. The name itself tells everything about this mode. Name itself tells everything about this mode. So there is synchronized, means two things are working together. This is what. So we are working together. We are synchronizing. I'm teaching you, you are learning. I'm giving you homework, you are doing the homework. If you're not doing the homework with me, it means that you're asynchronized with me. There's asynchronous. But I believe that we have a good synchronized relationship. Okay. So synchronized means, listen, there are only two type of breath. First is your mandatory breath, and second is your spontaneous breath. So understand one thing, these two breaths are synchronizing with itself. Next comes your intermediate, means intermediate beach mein, in between, intermediate. Mandatory means your mandatory breath, mandatory ventilation. It means that, let me give you an example of this. Let me explain you this furthermore. So in this ventilation, what is this? So you have set some mandatory breath. For example, 10 breath per minute. Can you calculate one breath in how many seconds? Boys, I'm counting on you. Be very, very quick. Tell me this. How many breath? One breath in how many seconds? Just calculate and tell me.
6 seconds. 6 seconds.
6
seconds, bache. How? Listen. You should know maths, okay? If you don't know maths, Women, we need to do more calculation than men. You should know, because we are working in grocery shopping. There are some kind of discount. We should be knowing 60% discount means what, 30% discount means what. Okay. Okay, just leave it. Let me make this thing. 10 breath is equal to 60 second. Okay.
60.
So 1 breath is equal to
6 seconds.
Understood how this comes? Yeah, very good. So a patient is taking breath, 1 breath every 6 seconds. This is what you have said, the mandatory ventilation. Okay. Then how does this working? Okay, this is how does it working? So 1 second, 1, 2, 3, 4, 5, 6 breath.
Breath.
1, 2, 3, 4, 5, 6 mandatory ventilation. Okay, but just imagine at next phase, 1, 2, 3, 4. Now at this second, patient wants to take breath. Now what ventilator will do? Ventilator will be like, listen, this is your breath. You are initiating the breath. So breath means a diaphragm is going down. It depends upon how much your diaphragm is going down, depends upon directly proportionate to the volume of air you will take in. So if a patient is initiating very low breath, so low volume will go. If a patient is initiating high, then more volume will go into the lung. So the machine will leave it on the patient. Listen, you are initiating that breath, so you take the volume, whatever you are directly proportionate to your initiation. I'm not going to give you the breath. I'm not going to give you the volume. But now at 5, 6, now I will give my mandatory breath, because my boss has told you to give mandatory breath. He told you to just to let you take breath at your pace. So this is your SIMV mode. This is also called as weaning mode. So when we want to remove patient from the ventilator, we want patient to initiate their breath. Okay. So we are not also killing the patient, because if you just keep a patient like this, the patient is not working, the respiratory function is not working correctly. So patient might go in hypoxia or some kind of respiratory failure. But as you have set some mandatory ventilation, this will keep a patient alive, but also independently help patient to take breath itself. And this is a very good mode. It's called weaning mode. Whenever you want to remove the patient, you will keep a patient on this mode. Understood, everyone, very, very clearly?
Yes, ma'am.
Yes, ma'am.
All the ventilator mode, ventilator in the tips. Yes or no?
Yes, ma'am.
Farhad, Priya, Suben, Govindraj, Bhavna, Uzma.
Yes, ma'am.
Yes, ma'am.
Okay. Should I summary this up again for you all? I know it's going too much, but I want everyone striking in your head.
Ma'am, one
Ventilator?
question, ma'am.
Yes, please ask.
One question, ma'am. It's so this ventilation and all, like if doctor says this many breath divided by 60, right? That much breath. I mean, if doctor is telling 15 breaths and divided by 60 is 4 breaths. I mean 4 seconds.
नहीं क्या बोला आपने? Repeat again.
Like if doctor is ordering a 15 breaths for a patient, so 15 divided by 60 seconds. I mean 1 minute.
15 breath is equal to 1 minute. 1
Yes,
minute is
ma'am.
equal to 60 seconds. So I can also write 15 breath is equal to 60 seconds. 1 breath is equal to 60 divided by 15. It is going to be 4. So
4
at every 4 seconds, 1 breath will be given.
given. So it depends on the doctor's order, right? Like if doctor says 15 breaths
Yeah.
or 16 breaths, we
Yeah.
have to follow according to that.
Yeah.
Okay.
You cannot decide.
Okay.
And doctor, don't worry, doctor is never going to give you 16 breath per minute. Don't worry.
Okay.
Doctor is also studying the same thing. Okay. If you get any kind of prescription, report, correlate, question the doctor physician prescription. Because it's not a correct prescription.
So the normal thing is 15.
No. What is normal respiratory rate?
12 to 18.
Yeah, 12 to 18. Simple. In between this range. Might go to 20 if some needed. Might go to 10, some needed. Depends. But never going to be exceeding like 20. Never more than this. Okay, depend on the case, depend upon the compliance of your lungs, depend upon your physiology of breath, depend how much your blood working, how much your muscles are working, how much your body wants you to keep you alive, depend upon so many factors. Okay, understood, Rupa? Your doubt? Now let's talk about some of the more setting. So there's one setting which is called as FiO2. What is FiO2? You will also set FiO2.
Thing is doubt. We need to get the clarity.
I will
from
send
your
you
notes.
notes. Okay, but listen one thing. If you're not playing with your shastra, if you're not playing with your weapon, and your weapons are your question papers, if you're not playing with your questions, nobody can pass this also. You should know how to read question and how to do question. Okay, practice question as much as you can. Just practice 85 question per day should be a benchmark. You should not sleep before doing 85 questions. Okay, you will practice from you have archer, practice it from archer. Okay, your boot camp archer. There are so many other. Kaplan, best, good, but very difficult. Don't start with Kaplan at the very end.
Sorry, once again, please. We need to note down.
No, I will teach you. You're a very initial. Just be with me for 1 month, then I will teach you what to do. Okay, let's study the basics. Then you will eventually you will be very good with the knowledge. Okay. I was talking about ventilator. We studied about ventilator. We studied about mode. Now let me tell you some model points related to this. First is your FiO2. It is the fraction of oxygen. So just imagine this is 1 liter. This is 1 can, and this much is your oxygen, and this much should be air. So how much? What is the fraction? So 2/3. So among these 3 parts, 2 part is filled with oxygen. This is the fraction of oxygen. Okay, understood? Basic easy. This is a fraction of oxygen. There's one setting. It is not a mode. It is a setting which is called PEEP. PEEP means
Positive
Positive
pressure.
and
and
the expiratory
expiratory
pressure.
pressure. This is a pressure which keeps your airway open. Listen, you want some certain amount of pressure to keep your airway open, right? Otherwise, it will collapse. So this is called PEEP. Understood, PEEP?
Yes,
ma'am.
ma'am.
Yes, ma'am.
Okay.
Yes, ma'am.
This was all. Now I'll tell you about ventilator alarm, but I want you to take break because this is going to be a long lecture today. So take break of 10 or 5 minutes and then we're going to come back.
Okay, ma'am.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Okay, everyone, back to the class. Rupa, Priya, Farhan, Havna.
Yes, ma'am, we are here.
Yes, good to hear.
Yes, ma'am.
So you got a break after so many long days, right? I have to give you a break. I have to give you a break. Make you feel happy. Okay. The next important topic is your ventilator alarms. Okay, what do you mean ventilator and alarms? Suban Khan. Suban Khalin, are you a boy or a girl? Yep. I cannot make out her name, so I asked.
Ma'am, Sumbal is female.
Okay, Suban is female. Okay. Okay, Suban is silent. Because your name, the last, what we say?
Father
The
name,
title.
ma'am.
Surname.
They
Yeah,
have a father
title.
name also.
Acha, acha. Okay, Suban. I thought you're a boy. I'm so sorry, Suban, till now. Uzma, I know is a female.
Okay, ma'am.
I know.
Okay, ma'am.
Yes, I know. Okay. So let's study about ventilator alarms. You must have worked in ICU. No, we have a good
Yes, ma'am.
candidate. Uzma, working in ICU?
यस मैम, डायलिसिस के पेशेंट हम उधर ही जाके करते हैं, तो वेंटिलेटर की वो सेटिंग का मुझे पता है.
Very good. Nice. Then you must have also heard about ventilator alarms that are very irritating, and we always push that no alarm when the ventilator try to make sounds. You all have seen this thing, right? Everybody have seen this thing. This is a very bad practice. No one should do that. Okay, this is wrong. Because the ventilator have two type of alarms. First is high pressure
ਟੇਬਲ ਤੇ
alarm.
ਪਈ ਆ ਉਹਦੇ ਵਿੱਚ ਇੱਕ ਗੋਲੀ ਹੋਣੀਆਂ ਜਿਹੜੀਆਂ ਏਦਾਂ 5 ਗੋਲੀਆਂ ਹਾਂ ਪੀਣ ਵਾਲੀ ਵੀ ਪੀਣੀ ਤੇ ਗੋਲੀ ਵੀ ਖਾਣੀ ਏਦਾਂ
Yes, Priya. Then we have second is low pressure alarm. One is high pressure alarm and second is low pressure alarm.
Low pressure alarm.
So exactly why this pressure alerts? In high pressure alarm, just imagine this is your ventilator and ventilator is trying to give the set of volume that you have asked the patient to give. So ventilator is giving this volume, and if to give this volume of oxygen to the patient, if to give this volume of oxygen to the patient, when in this condition, when the ventilator had put so much of pressure to give this fixed volume, so at that moment of time, the ventilation alarm will go out. It's going to blow up. Like, you want to give certain amount of pressure to the patient, you want to give certain amount of volume to the patient. In order to do that, when the ventilator is putting so much of pressure to give that volume, this is called as high pressure alarm. Then high pressure alarm will come. So you need to check is any kind of
Secretion,
blockage.
madam. Ma'am, secretion in airway.
Yes, any kind of
that
blockage
time.
due
Yes,
to
ma'am, at that
secretion.
time.
Yes.
Yes.
Then is there any kind of kink? Might be. Or the patient itself had chewed
Maybe the tube is displaced.
Tube block.
Yes. Tube
Tube block.
Or the patient is chewing the tube. The patient is biting the tube.
Yes.
Yes,
Any
yes.
kind of obstruction, any kind of blockage which is preventing to give that
Obstruction
fixed
in
amount
airway.
of volume to the patient. This is called as your high pressure alarm.
High
So at that
pressure
time,
alarm.
you are going to look the machine. Okay, is anything problem with the machine? Is the blockage in the machine? Okay. Look at the patient. Is the patient is chewing or not? So at this time, the first you're going to look at the patient, like biting, kinking, folding, tubings, or secretion. So if there is secretion, then take out the secretion. If there is a biting, remove the biting. If there is a kink, unkink. If the patient is chewing, remove the tubing from the mouth. Understood? This
Yes,
is what you
ma'am.
have to do. The second is low pressure alarm. In low pressure alarm, listen, this is the ventilator and this is attached to the oxygen, okay? to the patient. Ventilator will blow low pressure alarm when there is any kind of
Tubing
disturbing.
leaking.
Yeah.
Tubing leaking. Madam,
Yes.
just tubing ventilator,
Yes.
tubing
Any
leaking.
kind of leakage, or there is empty of the
Oxygen
or
cylinder
oxygen
disconnected.
empty, or there's leakage in the tubing, then there is a low pressure alarm. Okay. Understood? So
Yes.
disconnection of the tubing, or just patient remove the tubing from the mouth,
Yes.
or check the air leak or oxygen cylinder. Okay. Next question come. What if my ventilator stopped working?
We need to immediately start with the EMBO.
Very good. Immediately start with mandatory ventilation. Immediately start with
Yeah,
ambu
and side by side we will check connection
Yes.
of the ventilator.
Yes. Give me one second. Rohanjit, I can see you. Okay. So if your ventilator stop working, just go for direct mandatory manual bag. Okay.
Ambo bag.
Ambu bag.
Yes.
Right. Or then call HCP. But first do manual breathing. Then go for HCP. Okay. Understood? Next setting. You know the setting? FiO2, tidal volume, PEEP, rate. We have already. So what is tidal volume? I have taught you in the very first beginning.
Uh, volume of the
Amount.
care that client receive with the each breath.
Yes. And the volume of air the patient is taking and removing when the patient is normal.
Resting period.
Next. This was all about ventilator. Understood? Now let's talk about one very, very important thing. That is your, how will you ventilate a patient? There are two methods. Either you go for oral tube in emergency, or you make a
Non-invasive.
tracheostomy. Right?
Or non-invasive.
Yeah, it can be invasive, it can be non-invasive. Non-invasive, you know the thing. When you want to ventilate a patient, you will take a laryngoscope, you will put in the mouth, tongue braid, laryngoscope, you will put your ED tube in the patient's trachea or esophagus.
Trachea.
Sometimes we go to the esophagus also. Don't worry. In the trachea, yeah. And you want to seal it right side, not on the front, left side or right side. You can go for left side. After some
Left
time,
side.
you need to change the position also. Every time it's not going to be at the right side. Like they depend upon the protocol of a hospital, it depends upon. But it usually changes. Like after 1 day or 2 days, we will change the position from this side to this side. Okay. Understood? And you're going to tape it like these 3 tape. 1, 2, 3. One around this, second crisscross. You know how to attach the tubing. You must have cut those.
Yes, ma'am.
That's not going to come because there has been different methods which is used. Okay, this was about your oral. Now let's talk about your tracheostomy. Do you know what tracheostomy is? Anyone? Ostomy means
Opening.
Open.
what?
It's a surgical opening in the trachea.
Yes, it is a surgical opening in the trachea. Very good. Now, let's talk about some of the important things that you should know. Is this a sterile procedure or a clean procedure?
Sterile
Sterile
procedure.
Yes. But in this thing, understand your dominant hand will be your sterile, your non-dominant hand will be your clean. Write it down.
Say it again, ma'am.
Your dominant hand is going to be clean. Your non-dominant hand is going to be sterile. Your non-dominant hand is going to be clean. Write it down. Okay. So just imagine this is my trachea and I have made one hole over here. This was the work of a surgical team. They created a hole in my trachea and we named it as tracheostomy. Now, there is something which is called as tracheostomy care that every day, every shift you as a nurse has to do. Okay, this will be done by an RN or LPN. Okay, this can be done. This will be not been done by an UAP. There should be 1 finger of gap between the tie and the neck. If this is a neck, okay, there has to be 1 finger gap. Write it down, 1 finger gap. I'm just speaking you right because it's going to take a lot of time. There should be a flower knot. You know what flower knot that we learned in when we were kids? Make flower
Yes,
knots.
ma'am.
Flower knot. Will you knot back or at the side?
Side.
Very good. At a side. Do not just tie it at the back. While changing the tie, you are going to put the new tie over the old tie and then remove the old tie. Write it down. When changing the tie, you are going to put the new tie over the old tie, then remove the old tie. If you will not do this thing, there will be a very fast cough and patient will remove this tracheostomy from the tracheostomy cannula from the throat, and then you are making an open airway. Air respiratory will get compromised. Okay, written down, very, very understood. Listen, you want to change this tie. This is my old tie. So what I will do? First, I will put a new tie over it, knot it. Then I will untie from here, and then I will remove this. Then I will just take out this old tie. Understood? Now I have new tie. Why? Because tie is no sterile. Tie is not sterile. Obviously, you know, this is very clean. Just remove it. Next. Suction before removing the tie. If you want to remove the tie, suction it first. If you want to do a tracheostomy care, first you need to suction it out. Okay. Next, clean with half strength H2O2 or NS. Okay, this is one thing. If this is my tracheostomy, there's one cannula which I put. Okay. Outer cannula, inner cannula. If there's inner cannula also. We generally remove this cannula and we exchange it nowadays because there's disposable one are coming. You must have done this thing. But old time, they were metal cannulas. So you cannot dispose that. You need to clean it. So those were cleaned with H2O2 or NS. What is H2O2? Hydrogen
Present peroxide.
peroxide. Very good. Hydrogen peroxide. Okay. While doing tracheostomy care, you're going to keep patient on which position?
Semi-fowler position. Fowler position.
Upright. Upright.
Right.
Okay. Whenever you're doing tracheostomy care, you're going to keep ambu bag, oxygen cylinder, emergency kit, suction kit, 2 rescue cannula at the bedside. Ambu bag, oxygen, emergency kit at the bedside. 2 size cannula. one size of same that you had put, and the second is going to be smaller size, one size smaller than the new one.
Ma'am, ambu bag, oxygen kit, and then what?
Emergency kit, suction, oxygen, ambu bag, suction, emergency kit, and tube, rescue, or reserve cannula. 2 reserve cannula.
One small, one same size.
Yes, one small, one size smaller than the previous one. One of size small, second is smaller than the previous one. Understood? There should be one communication media at the bedside because patient cannot communicate with you with tracheostomy on or with ET tube when you have done a tracheostomy tube. So there should be a communication. Chalk and marker. Nowadays phones are coming. Nowadays, it was earlier also. Next. A good question comes to you. What if my tracheostomy come out? Then what will I do? What if my tracheostomy comes out, dislodged? What will I do? If this is a mature one, mature means?
Old one.
Yes, more than 7 days. Okay. Or depend upon if this is my immature. Immature means it has been only less than 7 days to my tracheostomy. It has been less than 7 days till I make a tracheostomy. So mature or immature. If it is mature, then RN can reinsert the new cannula. Okay. Then immediately ambu bag and ventilate, then call HCP.
Ma'am, please repeat.
I'm saying that if the tracheostomy tube has been removed, okay, this cannula has been removed from your tracheostomy, then what do we do? If it has been, you had created, the doctor has created the tracheostomy on 1/8/2025. The tracheostomy cannula removed on 10/8/2025. It means that it has been 7 days, more than 7 days. Then it means that the wound must have been healed. The wound that you had created, the stoma that you had created, it has been healed till now, since now. Then what are you going to do? You're going to reinsert the cannula into the tracheostomy as RN. Okay. Then just ventilate it, reinsert it and ventilate because you cannot leave it. So you need to ventilate at the same time. Reinsert it, just ventilate. Try to reinsert. It can't just ventilate the patient and then call HCP. Okay. Never use gauze piece. Never just seal it with gauze piece because the gauze piece contains threads and it can get stick to the wound and it can cause infection. Never use gauze piece. Use occlusive tape. You can use it occlusive tape to just seal it off. Understood?
Yes, ma'am.
Now the question comes, if
So we
it
have
is
to put the
immature.
occlusive dressing also beside the bedside table,
Yes,
ma'am?
you can keep occlusive tray. Yes, keep it. It comes under the emergency tray only.
Okay.
Immature, RN cannot reinsert. If RN cannot, LPN can't. RN cannot reinsert the cannula. Cover it, ambu bag from mouth. Ventilate the patient, HCP. Occlusive tape, call an HCP. Understood?
Yes, ma'am.
Yes, ma'am.
This was all about
Ma'am.
your ventilator, tracheostomy care, and what if your cannula falls out? Now let's talk about some suction. Suction is going to come important. So these are the only last topics. Tomorrow you're going to do full-fledged question and answers of respiratory. We are done with respiratory. Atelectasis is the homework. You're going to study about atelectasis and tell me what is atelectasis is.
Okay.
After that, we have just completed every topic of your respiratory. Suction. How many of you have done suction?
Yes, ma'am.
Everybody.
Everyone has done suction? Okay.
Suction is very difficult procedure, ma'am.
Yes, you're right, Uzma. It took decade to learn suction. Yes, Govind, isn't it a difficult procedure? Govind
Yes,
is
yes.
learning suction.
Yeah, that is some technique is there that
Yes,
we need to
there
learn
is
that.
so much of techniques.
Yeah.
Yes, it's so easy. Don't worry. Govind, have you ever done suction?
Yeah, I worked in ICU.
You have worked in ICU.
Yeah.
Yes, cool. So you must have been very much aware of a suction every second, one patient or the other. Okay, just leave. We need it. We need to do suction. Okay. So tell me one thing, Govind Raj. So when do you do suction? Good question comes. When do you do suction?
So in case patient struggling
Yeah.
that time, at the same time physiotherapy, after the physiotherapy or before the physiotherapy, we need to do
Very good.
the section.
Is there a time limit? Like every 2 hours, every 3 hours?
No time limit.
No,
Very
ma'am,
good.
no time limit.
Very good. No time. Dude, it's done on PNR, means when needed. When needed. There's no 2 hours, no 3 hours. Just depends upon when patient needs it. You're going to suction the patient. So what are the signs and
Ma'am,
symptoms?
just depend on mucus and secretion.
Yes.
Patient.
Yes. Write it down. It depends if your oxygen saturation is dropping. Then do a suction. Patient is
Yes.
having shortness of breath. Do suction. RN can do. UAP can do. LPN can do. In government hospital, family member also do. You have seen this thing?
Yes, ma'am.
Yes,
Shikala?
ma'am.
Govind Raj?
Yes, ma'am.
Family
Yes,
member
yes.
doing?
I'm here.
Yes. We train family members to do, because some people are ventilated at home. So family member, we teach them how to do suction. Okay.
Yeah,
Next.
some bedridden patients prolonged in hospital means that
Yes.
that doctor advised to take home and you can take care. So
Yes.
there are
Semi
also
followers. Yes, yes. Govind Raj.
yes,
Semi
madam.
follower position, upright position is given.
Better to little bit 30-degree flat position. 30-degree elevated
36 degree. Semi 60.
semi.
60 is good. Next come. Okay. If a patient is unconscious,
Yes,
silent.
ma'am.
Silently. Book says silently. Next the question is saying, before suction, you are going to pre-oxygenate the patient.
Yes.
Hyperoxygenate and pre-oxygenate. Oxygenate, or you can just go for hyperoxygenate the patient before suctioning. Okay. Do you do suction while inserting the cannula or while removing the cannula? Which cannula is used? Name. Yakur?
Yanker.
Yankur.
Young
You do
yes, ma'am.
Suction anchor.
suction anchor. Yakur hai. In my hospital, I use Yakur.
While taking out it, ma'am.
Very good. By removing the cannula, you will do suction. Okay. How you know that how much depth you need to go? So this is my trachea. Trachea is divided into
2.
bronchi. This is basic. You cannot forget this thing. Okay. Okay. Tell me one thing. This area is called carina. You know this is called carina. And automatically this area known as carina. So whenever you're going to put the tubing into this thing, once you will feel the resistance, remove it 2 to 4 or 5 inches. Remove it and then start doing the suction. One suction should be never more than 15 seconds.
Yeah.
One section 10 to 15 seconds, never more than 10 to 15 seconds.
Yes, ma'am.
One suction up to 10 to 15 seconds. Okay. And maximum 3 suction at a time. 1 second, not more than 10 to 15 seconds. And the maximum you can do 3 to 4 suction. Understood?
Yes, ma'am.
Yes, ma'am.
Suction is a negative pressure. Then what is the pressure? What is the pressure of suction? If you're talking about infant, or we are talking about children, or we are talking about adult. If you're talking about infant, it should be not more than 80 mmHg. If you're talking about children, it should be not more than 100 mmHg. If you're talking about adult, it should be not more
120.
than 120 mmHg. Can you remember this all?
Yes, ma'am.
Yes, ma'am.
Okay. Do not do ABG just after suctioning the patient, because it's going to show some kind of variation. After the suctioning, do not do ABG for at least 20 to 30 minutes, and post oxygenate the patient after suctioning. Try 2 points more.
Ma'am, repeat, ma'am, please. Do
I'm
not
saying
do ABG after suctioning.
till 20 to 30 minutes. Okay. And
Okay.
hyper oxygenate the patient after suctioning.
Oh, okay.
Next, let's talk about some respiratory therapy.
Ma'am, please repeat the last line because my mic is not get that.
Yeah, I'm going to repeat it. I'm saying, do not do suctioning, do not do ABG after doing suctioning, like approx 10 to 20 minutes. Then do ABG if needed. Okay. After suctioning, you need to oxygenate the patient with 100% oxygen. FIU to 100% oxygen for 1 to 2 minutes. Oxygenate the patient. Okay. Cool. Understood?
Yes, ma'am.
Yes.
Yes, ma'am.
Next come your respiratory or therapy or oxygen therapy. You can call it anything. Oxygen therapy. Just simply ask you, what are the method to give oxygen to the patient? Just you name it, I will tell you. Can you give oxygen through nasal cannula?
Cannula,
Yes, ma'am.
Can you give through?
venture mask.
Venturi mask.
No, this is simple mask. Simple mask.
Oxygen mask.
Yeah.
Face
Yeah.
mask.
Can you give? Yes. Through respiratory hood?
Yes, ma'am.
By pop. Okay.
Yes. Can you give a machine which is called CPAP and BiPAP?
Yes.
Yes. Yes.
Yes,
Yes,
ma'am.
ma'am.
Yes. Can you give patient through
Non-breathing.
yes, I'm trying to make that. I'm so sorry, I'm not good with making diagrams, but I hope you
Yes.
respect it. Okay. Reservoir. Okay. This is non-rebreather mask, and there's something called rebreather mask also. There's something called Venturi mask. Venturi mask look like this is the mask. There has been color coding. And this has been to oxygen. Anybody have ever heard of oxygen through blood? Can you give oxygen through blood? How many of you have ever worked in NICU? Neonatal ICU, a good neonatal ICU.
No, ma'am. No working.
Have you ever heard of this machine, Farhad?
Okay.
No, ma'am. I've never worked.
No, I'm asking, do you have you ever heard about this machine, ECMO?
No.
No, Gavin, have you ever heard of this machine, ECMO?
Yes, yes. When I worked in ICU, that time used it.
Very good. It is called an extracorporeal membrane oxygenation. You should know about this machine also. So let's do one thing. Let's grab some photos and then study each of them. Okay? Easy, good, better way to study. Let me tell you about some basic venturi mask first. So these are the only ways you can oxygenate a patient. Okay? There might be some other, you can name it. Let's talk about venturi mask.
We use for COPD for the main patients.
Very good. We use for COPD. What is the best? First best? If COPD is not available, then if venture is not, what is the first priority? BiPAP.
Nasal can.
BiPAP.
Oh, Kavaljeet, COPD, BiPAP, then venturi. So, this is the venturi mask. Okay. So what venturi mask is doing? In the venturi mask, can you see there's a slit? One slit. Can you see these slits?
Mhm.
So what venturi mask is doing? Venturi mask is one. I'm making a good venturi mask, so I'm just replicating this diagram. Okay. I don't know what I mean. Just leave it. So there's one funnel kind of thing is connected with some slit. So this is called tubings. What is the purpose of this tubing? One, you will connect with this oxygen. 100% oxygen is coming from here. But from the air, the oxygen is getting mixed up. So you're not giving just oxygen to the patient, you're giving, you can decide a fraction of oxygen via changing these nozzles. Or you can say adapters, whatever you would feel like you can say. Because there are slit, so slit will depend upon how much oxygen patient needs. Okay. You can change the nozzle depending on the need. So let's see. Just look at this, these. Okay. So from blue one, you will get 24% of oxygen. With white,
4 liter.
no, at 4 liter, you will get 28%.
28%.
28%. At 6 liter, you will get 31%. At 8 liter, you will get 35%. At 8 liter, you will get 40%. At 12 liter, you will 60%. So it depends upon the color coding that you are using. And then you can change the
Ma'am, but
FIO.
for COPD, we can't, I mean, the oxygen supposed to be 2 liters per minute, ma'am. Like we won't give high.
If you are giving through mask and
Okay.
intranasal. Here, these are best because here you're not giving just oxygen to the
Okay.
patient. You are
Oxygen.
using environmental air. You're just not taking direct from the pipe, direct to the nose. No.
Okay.
There is the air is getting mixed. Okay. And here expel out from air also from this nose. Understood about venturi mask? Color coding will decide how much percentage of air we are taking in. Understood?
Yes, ma'am.
Let's
Yes,
talk
ma'am.
about one more important topic, that one more type is your rebreather mask and non-rebreather mask. Okay. Let me show you more picture. Not clear. There's rebreather and there's partial rebreather. Just write it down, correct it down. There's rebreather and there's partial rebreather. Non-rebreather also, but not that important. We're talking about rebreather and partial rebreather mask. Non-rebreather also. Good picture.
Non-rebreather and partial rebreather.
Partial rebreather, non-rebreather. Partial rebreather and non-rebreather. Okay. Just look at this image. 1 second. Let me do a security check. Just look at this image. Can you see there's one nozzle over here? There's one covering over it, like a flap. Everybody just look at and appreciate there's a flap. So what is happening over here? There's a tube which is connected to this bag. This bag is called reservoir bag. So 100% oxygen is collected over here. Okay. 100% oxygen is collected over here. So what is happening? When I'm putting this mask on my face, mask on my face, what is happening? There's a box, there is a reservoir bag where 100% oxygen is being collected. Okay. When I'm exhaling, there's a two flaps. So these flaps get open up because I'm blowing air. So when I'm blowing air, this nozzle over here get closed. This is closed, but due to my force, these valves get open and I expirating out the carbon dioxide. But when I'm inhaling, I'm sucking out air. So this will get closed, okay? And this valve get open and 100% oxygen I'm taking it. Understood? There is unidirectional. Expire. Only you can expire. Only you can inspiration. This will only get open when you will expirate air. And this will get only open when you expirate out. This is non-rebreather mask. You are just taking 100%. Best in burns. Non-rebreather mask. 100% oxygen to the body at that time.
Carbon monoxide.
Very good. Carbon monoxide you can give. Understood? Kabaljeet, Govind
So
Raj,
ma'am,
Priya.
simply we just take 100% oxygen with this mask.
Yes, you're taking 100% oxygen. What happened in simple face mask? There are two open slit which usually get mixed up. And you can't give like good amount of oxygen through that. Very like 4 to 6 liters you can give maximum. Through this, you can give 100% oxygen. Okay. And remember one thing, you are going to keep it on hydration. You're going to put water in a water chamber whenever you're giving oxygen to the patient. This is you should know. Yes. Okay.
Yes, ma'am.
Now there's one mask which is called partial rebreather. Like this one. There is small dot where it get mixed up. You can just, so there's a mixed up. So mixed inspired and expired gases over there. So whenever expiration, so your expired gas also comes over here. So when you were, then it is also connected to 100%. So you're rebreathing your same air. So this is called rebreather mask. Do you know in hyperalkalosis, where patient is hyperventilating, the patient removes so much of carbon dioxide in the body. You want to preserve those carbon dioxide. So we ask patient to blow in a paper bag and breathe the same carbon dioxide. That time we need it when a patient is hyperventilating. Okay, we ask patient,
Panic attacks.
we want to breathe, take own breath. Understood till now? Never, never,
Yes,
never,
ma'am.
never do smoking when patient is on oxygen, ventilate, anything. No smoking. This is basic. You should know this thing. Clear? Are you all done with the topics?
Yes, ma'am, but please kindly send your ventilators notes.
I think some internet problem from one side.
Yes, yes, yes.
Everyone,
Yes,
Yes,
ma'am.
madam.
you're done with
Yes,
rest.
ma'am.
Your homework is to go and read about atelectasis.
We'll
Okay,
do it.
ma'am.
You will do
Ma'am.
it. Promise.
Yeah.
From good
Yes.
source. Do not go to ChatGPT and simply ask, are you practicing your questions? I've sent you one PDF yesterday. Did you read that? Has a good notes. You can just read those PDF.
Okay.
Okay.
Yes,
We'll
ma'am.
do
Online.
it.
And I will send
Yeah,
you my
that is.
notes as well as. But it matters more when I'm teaching you face to face rather than notes. So you can just write what I'm teaching you. I give you more knowledge than.
Yeah,
Okay.
better you can send all the PDF copy about a respiratory system.
Yes, already I've sent you one PDF copy. I'm going
Yeah.
to send you my notes
Yes,
today.
2-3 sessions you send, but not all the sessions.
Yeah, but you need to make your own notes. You cannot
Yeah,
copy what I have.
that is okay. We can take this some short notes.
Yes, I will give you. Don't worry. I'm talking about ECMO. One thing I read, ECMO.
Yes.
So what is extracorporeal?
Membrane notes.
Corpse means corporeal means anybody know?
Ma'am, your voice is breaking.
Still my voice is breaking?
No, it's fine.
Now it's all.
Yes. Extracorporeal membrane oxygenation. Extra means outside. Corpus mean body. Membranes mean through membrane. You're oxygenating the patient from outside through the skin. Are you listening to me?
Yes, yes.
Let me show you an ECMO machine so you will get better picture. It's just like it basically used in NICU pairs, okay, to give oxygen directly from the blood. Can you see the screen?
Yes,
No.
ma'am.
No, ma'am.
No, ma'am.
Oh, ma'am. Okay, just a second.
Now it's visible, ma'am.
Just look at this machine. So this is ECMO machine. One side, we are oxygenator. We are putting oxygen to the blood, and this is pumping the blood out of your body and into your body. So this is what exactly ECMO look like. Okay, ECMO machine. When you want to just oxygen the patient blood. Understood? Nothing more you need to know about this all.
Where will they connect, ma'am?
You have seen
Like
this machine?
Camera? No, I never seen.
Shashikala, have you? No.
No,
Don't worry,
ma'am.
even I haven't seen this thing in real life.
Okay.
Like
Okay.
dialysis machine, ma'am.
Yeah, no, something like dialysis. Yeah, you can think this. Something. Understood, everyone? Respiratory
Okay.
done. ABG, from EBG to medication to everything. Okay. You study about cough suppressant.
Cough suppressant.
You can give oxycodone, some kind of morphine, oxycodone, which can just depress your central nervous system. Sorry, your brain, which can cause and like morphine you can give for as a cough suppressant, like any drug which is active deactivate your central nervous system. You know what is given nowadays in the as a cough suppressant?
Fentanyl.
Yeah, you can read that. Read about that. Okay, so let's do some question tomorrow. Okay, any doubt, anyone?
No, ma'am.
No, ma'am.
Thank you so much. Have a good day. Have a good day.
Thank you, ma'am.
Thank you,
so much.
ma'am.
Ma'am, same to you.
Madam, as well as you can share that ABG notes also, because
We have
I
a
didn't
recorded
attend that
session of
class.
ABG on YouTube. Go and watch that. This is a good session. You will get everything about it. Okay.
Okay.
Hardly
Okay.
1 or
Right,
2
right.
hours. Just read those. Everything is clearly written over there. Or ask anyone from your group. They will forward you the notes of ABG.
Yeah, already Sasikala forward to me that link.
I'll
take it.
Use your WhatsApp very, very effectively. I'm repeating it. If anyone having doubt, anyone have any extra knowledge, put it on. Discuss at electricians over there. Okay. Okay. Have a good day. Thank you so much. Appreciate it.
Thank you.
Ma'am.
Thank you so much.
Thank you, ma'am.